AIDS. And so much has changed since then. Those early days were about recognition, about learning, about finding out. It was crisis management, and most people died. But today, most people living with HIV who are diagnosed in time and can access and tolerate effective treatment can anticipate life expectancy that equates to the general population. Most people live. And treatment has been revolutionary, which is why we decided to make it the theme for this webinar. Now, lots of other things have changed, and actually there is so much we could talk about. To fit it into an hour and a half is a struggle, but that's how we've taken our theme. But of course, it's been miraculous, but it's not the case for everybody, and inequity continues, both in terms of access and outcomes. And we have a way to go. So one of the aims for today is also to look forward. Now, in welcoming you today, I have the enormous privilege of being involved in both the organisations that are hosting this evening's webinar. Firstly, as the co-chair with Professor Kevin Fenton of the London Fast Track Cities Leadership Group, and Kevin is here with us on the call, and as the senior warden at the Worshipful Society of Apothecaries of London, and I can see Michael Farthing, Master Apothecary, and Jonathan Holliday, Junior Warden, on the call along with other apothecaries. So just a little bit about these organisations. The Fast Track Cities Initiative brings together more than 300 cities and metropolitan areas across the world, all of whom have come together behind the United Nations political declaration on ending AIDS by 2030. And in January 2018, London joined this global coalition with the commitment jointly made between the Mayor of London, Sadiq Khan, NHS England London, Public Health England London, and the London councils. And those four bodies put out the strategic aim of getting to zero by 2030 in our city. That's zero new HIV infections, zero HIV associated stigma, zero preventable deaths, and the best quality of life for Londoners living with HIV. And London has been at the forefront of the HIV response and has a world-leading resources of all sorts and skills. But the Fast Track Cities Initiative is about partnership, it's about collaborative working, it's about convening, it's about bringing people and organisations together behind a common purpose. And the leadership group that we formed in London is a unique forum that brings together representatives of all parts of the HIV sector in our city. It includes those four public bodies who jointly committed to the strategic aims, as well as people living with HIV, clinicians, voluntary sector organisations, amongst others. And we have the support of the Healthy London Partnerships, who make sure we have programmatic and infrastructure support to make a difference. And we have been supported financially over the first 3 years of the programme by NHS England London, for which we are extremely grateful. So let me turn to the Worshipful Society of Apothecaries of London. And of course, as we're thinking about London, this is a really important body within London, and it's an organisation based in the City of London, which has long-standing and very deep connection to HIV treatment and care. Although not all of you who are on the call will necessarily have come across it, and some of you may not even have heard about it before. The Worshipful Society of Apothecaries was established in 1617, and it's one of the largest of the City of London livery companies, and it represents particularly doctors and pharmacists. Now, the livery companies of the City of London evolved from London's medieval guilds, and they were the organisations that were responsible for training, for regulation in their trades and crafts and professions. And actually in 1815, the society was given the power to licence and regulate medical practitioners, which it went on doing until 1999. And the society has a really strong track record of education in specialist medical knowledge, and in particular in GU medicine and HIV, as well as in the history of medicine and pharmacy. And the Society has got 2 academic faculties, the Faculty of Conflict and Catastrophe Medicine and the Faculty of the History and Philosophy Medicine, both of which have international reputations for education and academic activities in these fields. And importantly, the Worshipful Society of Apothecaries has become very interested in urban health, and we're looking for ways to bring in the bigger picture of the health of cities. So this makes a very useful partnership, I think, between our 2 organisations. And in the past couple of years, the Society of Apothecaries has joined with other livery companies in health-related fields to form the Health Liveries Group. And that includes the Company of Nurses. And we're absolutely delighted that we have one of their number, Fiona Wallace, taking part in today's webinar. So the structure, we're going to plan it in 2 halves, a plenary scene setting first half, followed by an expert panel discussion. And Duncan Churchill will be chairing the first part and Kevin Fenton leading the discussion in the second part. Importantly, we're recording this, so please be aware that that's happening. We would like you to have your cameras and your microphones on mute while we're speaking to try and make sure that everything's clear. There is a chat function, the chat box, and if you could put your questions, queries, comments into the chat box, we will make sure that we're watching and do our very best to answer as many of them as we possibly can. So with no further ado, I'm going to introduce Dr. Duncan Churchill, who's going to chair the first part of the session. And Dr. Churchill is a consultant physician in Brighton. And I have to say with some envy that Brighton was the first UK city to get fast track city status, pipping London to the post, but London came second. And Duncan is the convener at the Worshipful Society of Apothecaries of the Diploma in HIV Medicine. So Duncan, I'm going to hand over to you now to take us forward into the seminar. Duncan.
Thank you, Jane. And I just wanted to say a couple of things, firstly about fast track cities, partly because we hear lots of initiatives a little bit like this, but I think that this is one initiative which, as far as the UK goes, at least, we are very likely to succeed at. To illustrate that, I could talk about my own experience. I became a consultant in Brighton in 1999, and at that time we were looking after about 600 people with HIV in our centre. In the subsequent 16 years, the size of our cohort grew by a little over 100 people per year across the whole period, so that by 2016 we had about 2,300 people that we were looking after. But in the 5 years since then, the cohort has not increased in size at all. And that's primarily because the number of new diagnoses and the number of new infections began to fall at about that time. So instead of having more than 100 people diagnosed each year, last year we had 25 new diagnoses. And so far this year, we're halfway through the year, we've had 11. The number of people who acquired their infection in the 6 months before their initial diagnoses in the last, from 2018 there were 9 of them, 2019 5, 2020 3, and so far this year we've had 1 recent infection out of the 8 for whom we have data. So we are well on track to eliminating HIV infection in the UK. Secondly, the diploma in HIV medicine. I'm the 4th convener of this diploma after firstly Professor Brian Gazzard, who was succeeded by the late Professor Martin Fisher, and then by Dr. David Asbo. And we're now in our 20th year. The diploma was established in 2002. And of course, at the beginning of the HIV epidemic in the UK, HIV doctors really were based in the places where people with HIV presented. So they came from specialties like respiratory medicine, gastroenterology, as well as sexual health and genitourinary medicine and infectious diseases. And we learnt on the job, and we learnt from our patients because there was no curriculum, there was no roadmap for how you trained in HIV medicine. But 20 years ago, a group of far-sighted individuals, including those people I mentioned before and others, set up the diploma at the Society of Apothecaries in order to accredit doctors as specialists in HIV medicine. And now for trainees in genitourinary medicine, the diploma is an exit exam, so that it's necessary for all trainees to pass the exam in order to complete their training in the specialty and eventually become consultants in genitourinary medicine. So far, 451 individuals have passed the diploma, and we have run 28 diets of the exam, and we're about to have our 29th one next month, and I hope there'll be many more people adding to that 451. The diploma is unique. As far as I'm aware, no other similar qualification exists in other countries. And I think this is maybe one part of the reason why we are doing very well in terms of getting on top of our HIV epidemic in the UK. But that's all I wanted to say about those two issues. So my main job is to introduce the speakers. And firstly, I'm delighted to introduce my colleague and friend, Professor Chloe Orkin, who has a very extensive CV that I'm not going to read out, but some of her many roles include that she was previously the external assessor for our diploma. She was also the recent past chair of the British HIV Association, and she's the chair-elect of the Medical Women's Federation. And she's also a professor of HIV medicine at Queen Mary University and Barts Health. So I'm going to hand you over to Chloe now.
Thank you so much, Duncan, and it's so lovely to see you all and see all the names of everybody that's here. I think the biggest accolade would be if I could manage to share my screen at the moment. So let's see what we can do there. Can you see it? Someone? Anyone?
Not yet. Not yet.
We can't see your screen yet, Chloe.
I've got a good view.
Oh, you've got a good view. That's lovely. Can you see this?
No, I can just see a picture of you.
Right, that's unfortunate. How about that? There we go.
Here we go.
Wonderful. Cooking with gas. Let me put the slideshow on from the start. Okay, so it's a great honour to be given the opportunity to speak about the clinician's perspective of HIV medicine. So thank you for the opportunity. I'll start with a short history of HIV medicine in terms of a treatment perspective. And as you've heard, HIV was discovered. The first therapy was, in fact, what we call a monotherapy, a single drug, which was discovered in 1987. We developed triple therapy around 1996-97. We moved to single tablet combinations in 2006, and then went to sort of very simple, easy to take, tolerable treatments around 2012-2013. And beyond that, we have now got to the point where we can start simplifying treatment and start doing creative things going forward. So we've come a very long way in a very short time. But what I draw your attention to is that this has not occurred in isolation and purely due to the prowess of the medical profession. There's been a proud and very important history of radical protest that has driven and propelled progress at every stage. And I cannot overstate this point, that at each point, people living with HIV have fought for the advances that have happened and fought hard and really effectively with some of the most incredible pieces of advocacy that I've ever seen. And I feel very proud to have been a small part of this journey. And I think that many of the people who've chosen this specialty are in themselves activists. And consider themselves to be activists and have stood together with patients and tried to get the best outcomes for everybody. And this is the pivotal moment in 1996, where the introduction of protease inhibitor containing triple therapy, and you suddenly start to see the death rates going miraculously down, having gone impossibly just up and up and up. And at that point, I was actually in South Africa completing my early years as a doctor, and lost pretty much all of my patients, as well as some of my very close friends. And that's what it propelled me into the specialty. So I experienced it from a different continent. But at this incredible moment, what became clear is that 3 drugs work better than 1 or 2 drugs. We had AZT, zidovudine, and it worked for a little bit. It was very exciting, but then it stopped working. And what you see in this slide here is that the proportion of people with viral suppression, and this means that the level of the virus is what we call undetectable, so low that we can't measure it. We see for the top bar where you have 3 drugs, the duration of maintenance of this very important thing is better for 3 drugs than 1 drug or 2 drugs, and that is really the key point at that stage. But for on the consumer end, on the participant end, on the people with HIV, what they had to do is they had to take literally handfuls of tablets. And things were very difficult, very intolerable, lots of side effects, and some people felt almost worse from the treatments than the actual disease and didn't take them. But since then, treatment and management strategies have really moved on, and we have continually focused on reducing antiretroviral exposure through reducing drug doses, dose frequency, number of drugs, developing a pipeline of investigational treatments. And now at this point, we're looking to deliver medications with different formulations, which I'll come on to a little later. And we have really great fixed dose combinations. And you can see there's a lot of for those that aren't in the field, impregnable abbreviations. But what I'd suggest you focus on is that there's a large number of single tablets. That's what I'm trying to depict here. And many different combinations, and the people in the middle and the concepts in the middle are meant to depict the fact that we're in the very fortunate situation that it's not a one size fits all. We have the ability to individualize treatment to try and accommodate different comorbidities, different issues that people may need, and to choose the right treatment for a specific person, and that's a real gift. Our goals are to enable a full and good life through rapid and durable virological suppression by managing the comorbidities and prescribing drugs that reduce polypharmacy and avoid drug interactions. One of our key aims is to support mental health. Living with HIV still is very difficult for people in terms of stigma. And lots of other reasons, and we have to assess and support this, and assess, use of any sort of misuse of substances and make appropriate referrals. We need to manage other comorbidities and problems, and we really need to address stigma and ultimately prevent transmission. And one of the key points that we really want to do now is we really want to facilitate life goals. We want to facilitate women and trans men to have pregnancies. We want to facilitate breastfeeding. We want to facilitate trans health and successful adolescent transitions. Choosing antiretroviral therapies, there are lots of factors to consider, and I know that there are people who are in the field in the audience, and so for that group of people, what I would say is we consider characteristics for all people with HIV. We consider individual characteristics, their immune systems, and various other parameters. We consider specific conditions, and we consider the properties of the regimen, the genetic barrier of the regimen, how strong it is, and how able it is to overcome potential resistance in the virus. With COVID, every person in the public has become an epidemiologist and understands the issue of mutations and resistance. So whoever you are, I'm sure you'll understand that concept now. In terms of recommended first-line treatments for first-line people, in other words, people starting treatment, there's a vast array of treatments. But if you look at the world's guidelines, starting with the European guidelines, moving through the US to the International AIDS Society and the WHO, for all of the guidelines, we're at a situation where we're mainly prescribing single tablets. And we're prescribing integrase inhibitors, which are more tolerable and have fewer side effects and fewer drug interactions. But at the bottom of the screen, you'll see that I've highlighted in red for the first time a combination which consists of just 2 drugs, not 3 drugs. And this is because the paradigm is shifting and our drugs are getting so potent and so tolerable that we're actually able to reduce the number of tablets. And this is a very important point because we're treating people for a very long life course, as Jane has said, and we want to allow people to live a long and healthy lifespan with as little drug exposure as we can manage while retaining potency. So what I'd say is HIV treatment in 2020 in the UK, in summary, in a one-word summary, it's tablets right now. However, in other disciplines, they have really harnessed the ability to improve engagement and outcomes. So for example, in contraception, they use long-acting contraception methods, and these are preferred by women regardless of where you are in the world, and they really reduce rates of pregnancy. In psychiatry, the use of long-acting antipsychotics has transformed relapse rates and hospitalizations. And for osteoporosis, being able to give yearly infusions has really helped people and stopped them from having to take handfuls of horrible oral medications. And there are a lot of technologies for drug delivery. We've got drug patches, we've got implants, potentially vaginal rings for prevention, wearable pumps like we know from diabetes. We've got long-acting injections, and I'm going to come on to that. There's also the potential for what we call oral nanomedicine, and this is really when you develop a very long-acting, degradable oral tablet, which lives in the body for a long time and releases the drug over a slow period of time. And there's really the potential that in the future, the whole circle will complete itself and we'll get back to a tablet being potentially the ideal treatment. But right now, we're in a situation where we have the first time ever in HIV got a long-acting injectable treatment, which can be given after an all-induction therapy. And what we can see here in this particular presentation, that this long-acting treatment worked just as well as an oral comparator at 2 years. And so it's come into the US guidelines and the European guidelines now for the first time. In the US guidelines, what I would say, I'd highlight to you that it can be used as an optimization strategy for people with HIV on oral treatment who have their viral load suppressed. But what they've done is they've really highlighted which people they think would be particularly beneficial to receive this drug. And they've talked about things like reducing pill fatigue, concerns about disclosure or stigma, difficulties making daily good decisions, and really to try and give injectable treatments to improve quality of life. So we have a long-acting treatment pipeline. Okay, and what you see here, it's a complicated slide, but what I'm trying to depict here is at the bottom is the viral life cycle. You can see the virus entering on one side, exiting on the other side to infect another cell. And all the way through the cell, there's different points in the life cycle where the virus acts. And what we see above it is that we now have drugs which are actually targeting every conceivable point in this HIV life cycle, which is truly incredible. And the important thing to say about these compounds, they're all being developed as long-acting treatments. Most of them are being developed as part of 2 drug regimens. So we've come a very long way. So right now in Europe, the European license for this long-acting treatment of cabotegravir pivirine, this new injectable treatment, is for every 2 monthly injection. And it's just been submitted. It's being submitted currently to NICE, and hopefully we'll have it in the NHS as soon as approval has been given, assuming that's what happens. But we also have a number of sort of late-stage trials, either in progress or imminent, evaluating weekly long-acting oral treatment. We're moving towards looking at 6 monthly options to optimize treatment for people on lots of tablets. There's already been a study that's looked at using a 6 monthly injectable treatment. Well, it's subcutaneous injection. And there's lots of potentials for novel combinations for implants and other injectables. And then you may have heard with COVID that there's such a thing called monoclonal antibodies or antibody therapies to give you immunity. Well, with HIV, we actually started off before they did in COVID, and we have antibodies that can actually provide potentially neutralization of the virus. And in monkeys, it's really exciting. They've managed to induce 4-year-long remissions. So in other words, they've taken monkeys with monkey forms of HIV, they've given them the antibody, they've stopped their therapy, and they've managed to keep the viral load undetectable for several years. And this is very similar to what we see in the cure scenarios of what we know of the London patient, the Berlin patient. So what we're hoping for is these drugs might really offer a hope of moving towards a cure. So who still needs these new treatments? There's still people who have been on treatments from the early stages who don't have options. They've gone through all of their therapy options for no fault of their own. They've ended up being, with us learning on providing them with the only available medications. They need treatments. People who have multiple other conditions, we need to simplify their treatments. People who can't or won't take oral treatments. And then we've got people who have not been considered in the drug trials. And I think it's important to say that all of these drugs have been licensed on the basis of commercial clinical trials which systemically exclude and underrepresent. In the last 6 drug trials, the median age of participants was 33. Trans people were not counted. People of color represented 33% of the population, and people with low CD4 counts, poor immunities were very poorly represented, and only around 15% of the cohorts enrolled were women. And this is not representative of 51% of the global epidemic who are women. Even further excluded are pregnant women who are not even considered to be included and excluded from all clinical trials, women who are breastfeeding, and children are often the last to receive medications. And this is important because women and trans people may have different outcomes. Adverse events may be different or worse in women, and this has been seen with certain drugs. Comorbidities like bone density and bone health, depression may differ, and drug interactions based on hormones may be different. And in pregnancy, the drug levels can be 25 to 30% lower than in non-pregnant women. Now, this is important because the median time delay to acquire the very first data on use of these new drugs after a drug has got its license and is being used in the hospitals is around 6 years for pregnant women and 8 years for breastfeeding women. So we just simply don't know anything about how the drugs are going to work. And this is a huge inequity, and there's a lot of work to be done. So what's the future going to hold? Well, and we all thought we knew that, but 2020 has been a year like no other. And we all thought that we knew how the world worked, the pre-COVID world. We saw our patients in clinic and we sent a few phone calls, a few emails and a few phone calls. But now with COVID, we've had to enter the world of telemedicine and we've had to really think about who we bring into the clinic, and we're doing our services differently. And we have to consider going forward into the future considerations for how we're going to maintain these excellent standards of research and of patient care, providing privacy and confidentiality, resources of infrastructure, equity of access for those who may be less fortunate in terms of what they have in terms of accessing these technologies, ensuring our empathic patient care continues, and ensuring engagement. We need a lot of research to try and get this right. And wherever we've got to so far, the disruption of COVID presents an enormous challenge. And we need to understand how this disruption is affecting every aspect of our care and treatment. And this is a challenge for us all and something we all need to rise to. But we need to rise to it with the input and advice from the patient community and the people that have always helped us to provide the best care. And I will end here, but no talk should ever be ended without the mention of the U equals U fact, which is that when people are undetectable, you cannot pass the virus on. And I'll be very happy to take questions at the end of the session. I'm sincerely hoping that I've stopped sharing my screen.
Yes, you have. Yeah. Thank you very much, Chloe. That was fantastic. You covered a huge amount of ground in that talk. There won't, of course, be questions in the usual sort of in the usual way, but there is the opportunity for you to send questions to Chloe in the chat. So I'd encourage you to do that, and hopefully we can try and address some of those in the discussion that follows. So my next job is to introduce Simon Collins. Chloe talked a little bit about some of the history of HIV treatment advocacy in the beginning of her talk, and Simon is an HIV treatment advocate who's been doing this for several decades. He's a person living with HIV, and again, he has a very long CV, which I couldn't possibly go through in any great detail, but he's a very active participant in research trials and in the process of producing guidelines. I think that Simon probably knows more about HIV than many HIV doctors do. He's certainly, he's never sat the diploma in HIV medicine, but I'm sure were he to do so, he'd have a very good shout. So I'm going to hand over to you, Simon, now. Still on mute, Simon.
It off to come off mute.
We can hear you now.
Great. Okay, thanks.
Are you muted again now?
Can anybody see slides?
Yeah, I can see the slides and I can hear you, Simon.
Fantastic, thanks. I'm just going to put the slides on slideshow. Great. So thank you for the invitation to talk. Thank you for including community in the programme and in the panel discussion afterwards. And of course, I wouldn't expect anything less, because I know Fast Track Cities and Beaver and the Worshipful company of Apothecaries work with community incredibly closely and have developed wonderful relationships over the years. I've got no financial disclosures. This was a slide I put together a few years ago for a talk on PrEP, and I used it. This is just some of my friends from the 80s who didn't survive to benefit from treatment, really, and then within a few weeks of giving that talk, I realised that actually I missed out half the people I knew, and that even since treatment's become available, unfortunately, there's other people who hadn't benefited as well from treatment. But then when I looked at the slide again this time, I like the fact that you can see, these are my close friends and everybody's smiling and laughing. And we had a real, it wasn't an easy time in the 80s, but actually none of this, for people who weren't born back then, nothing about HIV was expected. The 80s were, for most of us, a lively time. It was dynamic political time and social times, and none of us expected to become a patient at all. Expert or otherwise. So the talk today, I'm just going to come up with a few examples that might be useful for the panel discussion afterwards, and they're just observations from my perspective as somebody who's HIV positive. I'll talk a little bit about this idea of expert patients and also the overlap with peer support. A little bit about Denver principles and community engagement, and why it's so important to have people who are directly affected by a condition to be included in the way that condition's managed. And at the end, I've got a few examples of different examples of treatment information that have been produced at iBase. So the first thing that most HIV positive people learned, certainly before there was treatment, was that as individuals, no matter how good our healthcare and how good our doctors and clinics, was that actually as individuals we had the most to gain and the most to lose from getting treatment right. And that sort of focused the mind, and lots of us did become much more interested in HIV and treatment than we would have done about blood pressure or high cholesterol. And that by actively engaging with doctors, nurses, research, and sharing these decisions about our care, we probably got better care. If you understood what drugs were available and when they were coming, you could probably plan your life better. You could maybe understand what side effects you could put up with and which side effects weren't good enough. Most people learn, first thing we learned is something about a CD4 count, and roughly that's a good marker of how much HIV has damaged your immune system. If your CD4 count is high, back then you didn't used to have treatment even when treatment was developed, but steadily without treatment your CD4 count dropped. And if you were unlucky, you then had to learn a whole bunch of acronyms and abbreviations for complicated illnesses that became more serious as your CD4 count became lower. So people know about CMV and KS and MAC. And then we learned a little bit about viral load. Very luckily, viral load was developed just about the same time as treatment was developed. So it was a new technology for everyone. We learned a bit about drug resistance and the importance of adherence, but this was always as a choice. It wasn't that you had to learn this in order to be HIV positive. And then when I was asked to talk from the perspective of an expert patient, I thought it would probably be better to talk about an active patient, because just being informed about things doesn't mean you always make the right choices. And certainly over 25 years of being positive, I've made some good and bad choices, and it's not always been for the right reasons. So probably taking a single drug when it was available on expanded access, called 3TC, was just the wrong idea. I took bad advice, or I didn't understand the concept of drug resistance, but then just luckily I stopped it because it didn't affect my CD4 count. So sometimes there was a bit of trial and error, and the same for stopping other single drugs. So AZT just by itself didn't do very much for me. DDI just by itself didn't do very much for me. But I've also had amazing medical care and been very lucky with my doctors, I used to have a CMV, which is an infection that damages your eyesight when my CD4 count was very low. And I was the first person in the UK to stop CMV drugs on the basis of toxicity. But that was really because of the skill of Dr. Suzanne Mitchell, who was planning to do this in a research study. But the benefit of being active means you take active responsibility for decisions, whether they're right or wrong. And that's a much more realistic basis for healthcare. Back in 1983, just a couple of years after mainly gay men in America realized something bad was going on, there was a second AIDS conference where about a dozen HIV positive people, even though HIV hadn't been diagnosed back then, about a dozen people living with AIDS got together and they produced a one-pager on principles of putting people at the center of their own healthcare. And although this was an activist document, it was supported by activist doctors back then. So Joe Sonnabend in New York and Dr. Martis Conant in San Francisco. And that sort of brings forward some of the things Chloe was talking about activists coming from all walks of life. You really just need to decide that the current status quo isn't good enough, and you want to be able to try and make something a bit better. So the Denver principles were about self-empowerment, and they were about rights. People with AIDS who wanted rights. They wanted to be treated with dignity and with respect, and to be actively involved in decisions about their care, including whether they decided to take a treatment or not. Very early on, people living with HIV took control of language, or tried to. We didn't like being called sufferers or victims. We were people living with HIV, and that's followed on is now more common in terms of language about other health areas now. And the principles also included responsibilities about being careful with partners and not leading to further transmission. Very early on, certainly in the UK, there were hundreds of HIV organisations. I've just put a few in here. And generally, these organisations had a different feeling if they included HIV positive people throughout in terms of providing the services and leading the organisations. And again, in the UK, there were hundreds of resources and newsletters and magazines that focused, a lot of which are focused on treatment. The centre one here, this ATP one, when I started treatment, my CD4 count had been in single figures for at least a year, I think. I was not in such a great shape. I said I had CMV in both eyes, and I weighed about 45 kilos and was in and out of hospital with all sorts of things. And so I didn't really have any expectations that combination therapy would be any better or that it would work. And then as I started to become stronger, I was able to volunteer at a group called AIDS Treatment Project. And that was quite remarkable because it was organised by a group of people in a similar situation who'd experienced treatment and they'd understood that this stuff worked. And we had a phone line where people were calling, and really that's all they wanted to know. To have very complicated questions about side effects. They just want to know, is this going to work? Is it going to keep me alive? Can I tolerate whatever the side effects are? And it was a very moving experience. Not everyone was positive who worked there, and some of the best advocates were HIV negative. But as an organisation, we had benefits from working a little bit outside of the NHS hierarchical structure. Sometimes we could get away with saying things that would be more difficult if we were on the NHS. It was interesting that back then the awareness of the early side effects came because HIV positive people were reporting body changes to their doctors, and often not always believed, really. We were reporting odd things, ingrowing toenails and hair loss and thinning hair and these body changes. It made a big difference back then which protease inhibitor you used, and so having an independent community advocacy group meant you could bounce your idea off, see whether your doctor was recommending something you wanted to use. We highlighted the side effects with D4T early on, and we also helped introduce access to Newfill, which corrected the fat loss that some of us got. The publication we put out was called Dr. Fax. It was faxed to doctors' offices every 2 weeks, because that's how urgently and critically the information changed about how people were being treated. This is Paul Blanchard, who was an amazing activist, who was editor all the way through for Dr. Fax and also for iBase's HIV treatment bulletin. And then the other interesting thing is that we were doing this at a time when most other HIV organisations were at best cautious, and actually some were quite hostile to the idea of treatment. And the same was true with the medical approaches as well. As a community, we want to be included back, same as in the Denver principles. We want to be included at all stages of our care. We want to be included on guidelines. We want to be included on our personal care. If a big study is being planned, it'll actually work better if you include community when the study is being planned and on all various committees that are related to the studies. But there's also a term called meaningful involvement. So we don't just want to sit. It's quite challenging and isolating having no medical training, and then suddenly you're sitting in a room of all these medical experts knowing exactly what to say and whether what you say makes sense. So the meaningful involvement has to involve a certain amount of training and getting people confident in talking about these issues. So one of the responses we had is we set up a network of advocates back in 2002, and it started with about 25 people in a room, and steadily it grew. And you can see we're a shy and retiring bunch, and now there's more than 700 people in the UK connected in this advocacy network, and we have email discussion, and we meet 4 times a year. Been doing that virtually, and we're really supported by researchers that come and train us about statistics, or doctors that come and talk about TB or hepatitis and share their knowledge. Our goals are for better treatment. As Chloe showed, we started off on 20 pills a day, and then within a decade, different drug companies worked together to put 3 drugs in one, and then within 10 years later, we now have these 10 single pill combinations. I put a note in here later that actually Cipla, a generic company, was the first example of putting 3 pills in a single combination, and that was to enable access to lower middle income countries. These are the 10 pills. These were some of the early treatment issues we had. As activists, we were saying that dual therapy was no longer ethical once we knew that the triple therapy worked. We had examples of triple ART being used during pregnancy in 1998, and that reduced transmission to 0 when organisations were more concerned about toxicity of treatment. We understood the goal of getting an undetected viral load was essential to avoid drug resistance. And that the importance, actually, children needed higher doses because their bodies metabolized the drugs very quickly. There's a few other timeline examples because as a non-expert, I like it when experts learn. As you know, we only know what science teaches us. For the first 15 years of the epidemic, people thought there was a period of latency when HIV was sleeping. And then as viral load technology came, you realized that actually it was a continuous infection and the viral load was going up all the time. The first example of PrEP working with tenofovir was in 1995. 1998, US guidelines talked about early ART in order to prevent transmission. And you saw the slide from Chloe about U equals U and the partner study showing that there's 0 risk of transmission if undetectable. And of course, the biggest example of all is in 2000, various people said that ART is not for Africa or for anywhere other than a rich country. And now 24 million people are on treatment, although a third are still not on treatment. These are just a few examples of iBase non-technical guides. These are free in HIV clinics still. We use very simple language to explain treatment. These are examples of these guides that have been translated because we make them available without copyright across the world in other countries. This is IBASE moving into prevention. We've done lots of work on PrEP. These are the posters that Chloe also showed about U equals U. Incredibly exciting, dynamic medical breakthroughs have led to where we are now. And looking forward to, this is my last slide, looking forward to Zero, Fast Track Cities is doing amazing work, working with HIV communities to achieve these targets, and that it was unthinkable we would have these results even a few years ago. It keeps HIV in the awareness of the general public, and I'd say for 2030, the zero transmissions is easy. The exciting pipeline for current PrEP and what we have coming up means that you will be living in a different world in terms of HIV transmission in a couple of years' time, way before 2030. But zero preventable deaths and stigma are more difficult because late diagnosis is still a difficult issue in every country, and stigma, at least one in, I just saw a report that came out, a fantastic report come out from the Sophia Project and NAT showing that 1 in 6 women haven't told anyone else other than their doctor that they're HIV positive. So we have a huge amount of work to be doing here, and it's great to be doing it with such committed colleagues from other fields. So thank you.
Thank you, Simon, for a brilliant and very thought-provoking talk. And again, please address your questions to Simon in the chat, and we'll deal with those later. I particularly like the the little section when you were talking about mistakes that you'd made, and I'd love to hear maybe an elderly HIV physician talking about mistakes that we've all made, because I've never heard that talk from anybody ever. But anyway, thank you, Simon. And I'm going to hand over to my co-chair, Kevin Fenton, for the second section of the programme.
Thank you, Duncan, and good evening, everyone. I'm so pleased that you've been able to join us this evening for this event that reflects on the journey that we've been on over the past 40 years as we've tackled the HIV/AIDS pandemic, and to think about the stories and the narratives that we will tell and that we will speak about this pandemic. Because this pandemic has not only been about pain, and as you've heard from Chloe and from Simon, it has been a pandemic with other stories. It's about progress, the progress that we've made in treatment and care, in prevention, in policy, in the way we deliver healthcare programs, the ways in which we engage communities to deliver effective programs. HIV has fundamentally changed the way we practice medicine, the way we develop policy, and the ways in which we engage communities to be part of the solutions to their own health. But there are other narratives as well. The story of the pandemic is a story of people. And as Simon has said, having communities at the center of the response has characterized the HIV pandemic from day one, and other clinical diseases, other clinical conditions continually look to the advances in HIV, the lessons that we are learning in HIV to design programs, whether for heart disease, for mental health, or for other conditions. And that story and those narratives of people will be key as we think about the final mile of this journey of tackling this pandemic, as we set our sights on 2030. Now, as we move to the last third of this session, we'll be getting some other perspectives on the past 40 years. And I'm really pleased to invite 3 colleagues who have 5 minutes to give a brief view of their own perspectives of the pandemic from their unique positions as women, as people working in different aspects of medical practice, and of course, as members of the community. So to get us started, I'd like to invite Sophie Strachan to give her reflections. And I'm going to ask everyone, please use the chat, because we'll be going to the chat to stimulate the discussion towards the end of these brief presentations. Sophie, over to you. If you could introduce yourself, please, and then we'll get started.
Thank you very much, Kevin. Thank you very much to the organisers for the invitation. My name is Sophie Strachan. I am the current director of the Sophia Forum and also a sexual health advisor at the Chelsea and Westminster Hospital. I'm also a woman living with HIV and have been for 18 years. Just to give you little insight, the Sophia Forum is a UK-based charity, and we exist to advance the rights of all women living with and at risk of HIV. And we challenge unequal access to services and opportunities based on gender. And we do this through our advocacy research and policy work. There's just 4 points that I'd like to raise from a women's perspective, and I have reached out to some community members, so these are voices of a bigger community and not just my voice, which is really important. So, as Chloe said, women make up 51% of people globally living with HIV, but make up only 19% of HIV clinical trial participants. So data from clinical trials is not reflective of women's experiences, but that of men. And I know that Neca is going to touch on this a little bit more as we go through the presentations. A neglect around gender experiences and needs for women continue to affect the response to HIV globally. And without that, any response to health pandemics will fail women, especially those from racially minoritized communities. If we reflect on women leadership in HIV screening and antenatal settings, and how we can achieve that elsewhere in the development of HIV testing models to increase the uptake amongst women in all our diversities as we look to achieve zero infection by 2030. The role of treatment as prevention and U equals U messaging outside of men who have sex with men. And zero infection by 2030 can only be achieved if women have equal access to a combination of prevention options, PrEP being one of these. And currently in the UK, there is a significant disparity in knowledge, education and uptake of PrEP amongst women and other minoritized groups. So they're my key points at this stage, Kevin.
Wonderful. Thank you very much, Sophie. Our second colleague who will be reflecting is Fiona Wallace. And Fiona, I'm going to ask you if you could come on camera, introduce yourself, and we'd love to hear your perspective as a retired HIV specialist nurse. Fiona, I think you are on mute, so you may want to check.
Better? You can hear me now? Sorry. So I started working in HIV in 1988 as a sister of one of the HIV inpatients in London. And in the late 70s, early 80s, people were talking about person-centered care. And Jane Bruton at Imperial describes clearly that we looked at putting this theory into practice so that the person living with HIV was at the centre of their care. And that meant things like ward routines had to change. So, for example, in the early 80s, you might have people who were suffering from night sweats, didn't sleep well, and the hospital canteen would send up the breakfast at 7:30. And with the help of the third sector and volunteers, we managed to arrange meal times to suit the needs of the patient. And I think that was really important. Person-centered care sounds like a really grand thing, and it's based on assessment of the person's needs, both physically, socially, emotionally, and spiritual, and those of their nearest and their partners and family. So that was also very key, making quite sure we got that assessment. I think nurses at the time developed skills in advocacy and activism to ensure that we tried to meet the needs of the people we were looking after. And also at the time, confidentiality and was really key because of the fear and the stigma that surrounded HIV. And I do think that some of the policies and confidentiality that we had in place then have influence the privacy and dignity agenda of the NHS currently. And as you've heard, 1996 came along and we had highly active antiretroviral therapies. I think one of the points I'd like to make there was, although people perhaps felt physically better and their symptoms improved, quite often patients had spent time in a smaller world. Their world had reduced, and suddenly, I think a lot of us can relate to this, their confidence perhaps wasn't as great going forward. And the third sector really helped with building confidence skills and education and training and allowing people to move forward in a positive way. And it's the partnership working between many different sectors that I think is really important in HIV care, because it's about providing good care for the person where they're at. Nursing has developed, so the National HIV Nurses Association developed a framework of clinical care. So nurses started to do their own clinics, leadership and collaborative practice. So we started working more outreach with some of perhaps more marginalised and vulnerable groups to improve care. And then the 490s came, which was to ensure that 90% of the people were diagnosed with 90% on treatment, 90% undetectable viral load, and 90% with good quality of life. And I think the 490 is really key, and nurses had a part to play in that. Nursing has moved on as well. Generally, nurses are now prescribers. I was a prescriber. You can only prescribe in your own field. You can't suddenly decide that you're going to be a rheumatologist the next day and prescribe in that field. But it's really important because nurses are now prescribing PrEP and managing cases for PrEP. And I think the way forward will be nurses in HIV will perhaps work with some of the more vulnerable and marginalised groups, both for HIV care and treatment, but also in access for PrEP. And so finally, my final point is that my 30-year-old self in 1988 could never have envisaged a day of U equals U. I could never have envisaged a zero transmission by 2030. And so I would really like to thank all the healthcare staff, scientists, and most importantly, the patients who've made such development possible. And for vintage nurses such as myself who've cared for the same patient for many years, I look forward to growing old with them. Thank you.
Fantastic. Thank you so much, Fiona. Really, really powerful reflection from both you and Sophie on the journey that we've been on so far and the different perspectives as well, whether it's equity, whether it's the care that we're providing, the ways in which we're engaging our patients. We'll have a third reflection now from Dr. Neke Nwokolo, who will be reflecting from her perspective on the contribution of industry over the past 40 years. Neke.
Thanks very much, Kevin, and thanks, Jane, and everybody for having me. I'm Neke Nwokolo, and I work for Vive Healthcare, and some of you may know that this is an HIV pharmaceutical company. But I was also thinking about my role in this meeting, given who's organizing it. And I, like Duncan, was an examiner in the Society of Apothecaries. I was an examiner for the diploma in GU medicine, not the diploma in HIV medicine. And I am now also an apothecary. But I came to Vive from clinical practice as an HIV consultant at Chelsea and Westminster Hospital. So much of what has been spoken about before, I have also observed firsthand. But one of the things that I wanted to reflect on today is about what the drivers for drug development are, and particularly for the development of antiretrovirals. And I think that one of the most important drivers for drug development is unmet need. And I think this speaks very much to what Simon was talking about and Chloe with regard to the early days of antiretroviral therapy when we really had nothing. but also to some of what Sophie was speaking about in terms of ensuring that there is representation of all the people who would benefit or who stand to benefit from a treatment in terms of the clinical studies that look at who will be taking these medicines. I want to really pay tribute to the fact that, as Simon said, we would not be where we are today without community activists and advocates, or without listening to the experiences of patients ourselves. But also, as Chloe and Simon said, we should remember that there were also activists, nurses and doctors and other people from the community, not necessarily living with HIV, who are also involved in the activism that has led us to where we are now. And Kevin mentioned that HIV is viewed as a model for treatment and care across the medical profession. But I think that HIV is also viewed as a model across the pharmaceutical industry. And this is because of the demands of activists in demanding access to treatment and of an understanding of the development of the drug process that enabled them to participate very actively in the development of treatments. And at the beginning of the HIV epidemic, the critical need was to create medicines that saved lives. And people living with HIV and community activists were arguably the biggest drivers of this. And initially, you saw the handfuls of pills that Chloe showed you and that Simon mentioned, whereby people took many pills several times a day, most of which had terrible side effects. But over the years, in order to meet the changing treatment needs of our patients, which have evolved, we now have single tablet regimens, medicines that people can take once a day. But there is also an acknowledgement and understanding of the fact that for various reasons, many people struggle to take a pill every day, even if it's just one pill. And so we now have, as Chloe showed you in her slides, a pipeline of treatment whereby medicines that don't need to be taken every day are being developed, including injections and implants and tablets that may be taken less frequently than every day. And this is all being driven by the needs that patients articulate when they speak to their clinicians, when they speak to other people. And in order to end the HIV epidemic by 2030, which in many places will be a very big ask, but actually I think is actually achievable in the UK, it's crucial that people have choices that reflect their differing needs and their changing needs. So a person may have a particular need at one point in their life, but that need may change as they get older. We know that treatment also needs to evolve as people get older. At the beginning of the HIV epidemic, most people who were affected were very young. But as people living with HIV get older and start to experience age-related health conditions, new HIV treatments need to take this into account, so that we have treatments that have as little effect as possible on the treatments for the comorbidities or non-HIV related conditions that people get as they get older, but also on medicines that don't contribute to people's comorbidities. And it's crucial for us to strive to understand the unmet needs of the diverse populations that we know are affected by HIV, so that we can ensure adequate representation of everybody who, as I said earlier, stands to benefit from treatment. We know that with women, despite being the majority population affected by HIV worldwide, are only reflected in a very small number of clinical trial participants. We know that older people are not well represented in clinical trials, and we know that people of ethnic minority backgrounds are not represented. And so we really need to strive across the pharmaceutical industry to engage these different groups in understanding the importance of participating in clinical trials, but also in facilitating their participation. So one of the reasons that women may not participate as much as we would want them to in clinical trials is because they have challenges that mean that it's really difficult to. So it's our responsibility to try to rise to those challenges, to try to make sure that those challenges can be diminished so that women can participate in clinical trials, that people who don't understand why it's important to participate in clinical trials are given information that helps them to understand the importance of doing that. And so although we've come a long way, I think there is an acknowledgement that we still have a long way to go, but that engagement and collaboration are really important in doing this. So thanks very much.
Thanks. Excellent reflection there on the role of industry. And again, in the things that have changed and have evolved, I think the understanding of how we work with industry and how industry may be and can be, especially the pharmaceutical companies, can be an effective partner to policymakers, to those delivering programs in order to achieve mutual aims. And I think that journey over the past 40 years has been one of challenge, it's been one of growth, but also one of evolution as well. So colleagues, we have just about 20 minutes for the rest of the session, and it really is now, I think, an exciting time for us to have a conversation about the last 40 years, but more importantly, what's in store for us as we think towards the ending of HIV transmission, perhaps in the next decade. What does this mean for us? But I know on the minds of many people here, we are currently in the midst of a new pandemic, and COVID has touched our lives in so many ways. So whether it's the millions of people in our country who've acquired the infection, or the hundreds of thousands of people died from this disease. So to get our discussion started this evening, I wanted to ask panel members, what are we learning, or what are you learning from the COVID pandemic that will change or evolve what we need to do with the HIV pandemic moving forward? What is COVID teaching you or us that we should be taking forward as we think about the years ahead? So Chloe, I'll start with you. Simon, I'll go to you next. And then Sophie, I'll ask you as well, just to prepare you all. Chloe.
Well, what COVID taught me as someone who is leading on vaccine, a sort of research delivery for Bart's Health, is that the things that we thought were impossible to do quickly or at all are possible. Mm-hmm. For example, the NHS, digitalization was seen as something, a 10-year plan. It was introduced overnight. For telehealth, telemedicine was introduced practically overnight. Once we couldn't see people face to face, things that seemed impossible were not impossible. Research governance, delivering a vaccine trial in a library like we did, getting the drug from point A to point B, redesigning services, and also realizing that understanding that from the patient's perspective, actually, doing things for some people, for certain people, not seeing people face to face is actually preferable. And for other people, it isn't. And understanding that COVID, the messaging in COVID around shielding affected people with HIV. We had a cohort of people who we've never been able to engage in care, who suddenly were terrified by the messaging, and they came back and they started taking treatment for the first time ever. And we've put in a big grant to study these people. It wasn't just our patients, it was people all over London. Somehow the public health messaging around COVID was so terrifying that people saw their HIV in a different light. And we really need to harness and understand all of these opportunities for good and bad, moving forward. But nothing's going to be the same.
Yeah, indeed. Simon, how about you? What has changed in the pandemic?
Access to information and research was fantastic. Suddenly everything that would be behind a paywall was open access. Mm-hmm. So for treatment advocates, it was easier to follow the research. And the scramble for drugs was actually very reminiscent of HIV, where people tried all sorts of remedies and ideas and pipes for anything that would work. And actually a lot of them also just with HIV didn't work, wasn't effective at all. And probably the big lesson, I think, is that that making a billion vaccine doses available is nowhere near enough for a global scale for what's going on. We can't plan to only make available 1 billion doses by the end of 2021. It's nowhere near fast enough, and maybe learn a little bit from the fact that everybody said art was impossible. It was impossible to give HIV treatment globally, and actually we've overcome that. And we need to have real activists from all walks of life, from politicians, from manufacturers, from finance, to make real access to vaccines a reality in all countries immediately. I'm not sure if that's quite your question, but it's been a really complicated year. But at the end, you've got this gold opportunity that vaccines can protect countries from COVID-19, and now we need to make sure people have access to vaccines.
Yeah, well, no, Simon, you hit the nail on the head, because as Chloe has said, the transformation in services and systems and achieving what we've been able to achieve means that we should challenge ourselves further when it comes to the next 10 years of HIV, and to dream the impossible, because we can do it and it shouldn't only be under threat. And as you've reflected with the last year, understanding that the pandemic means we have to pay attention to what's happening globally, because we're interconnected and intertwined, is going to be a key part of that final mile. And a narrative that says, as we go towards ending HIV transmission in the UK, how do we bring others with us on that journey, I think will be key. Sophie, how about you? What do you think in terms of what have you learned from the pandemic that can really help us to think differently about HIV? And then I'll go to Nneka and then Fiona.
Thank you. So I think it goes back to my first point around the neglect around gender experiences, and that without that, any response to a health pandemic is going to fail women. And I think, as I have heard you say and many other people across the last year or so, it's further highlighted the health inequalities. And within that, you have to take look at it through a gendered lens. And so I think moving forward, it again just highlights the need for much more research that will explore and help us understand individuals' intersectionalities around gender identity, the race, ethnicity, class. When people talk about the models that have been applied in terms of more telemedicine, for some that's really good and it makes it a lot more accessible for them. But within the third sector, a big conversation has been around data poverty, actually losing people. Whilst there is a cohort that have re-engaged in care that were previously disengaged, there is also reporting where patients have disengaged from care. So it is that balance going forward of, just finding that balance that, and I know that this isn't being said on this platform, but one model approach is not going to meet the needs of everybody. And we do have to think of those who have been disproportionately affected, not only by HIV, but also COVID.
Yeah. Great. Thanks, Sophie. Nneka and then Fiona, and then we'll move on to the second question. And I just want to acknowledge John Dugdale's comment in the chat, which speaks about the ways in which we were able to scale testing, engage the public in messaging around the disease, and to normalize preventive behaviors in a very short period of time is perhaps something that we should be taking out of this in terms of listening and learning. But Nneka, what do you think?
I think one reflection that I have is about how important communication has been in the pandemic, communication and collaboration. And I think about this from the point of view of clinical trials, because clinical trials, in clinical trials, people access treatment. And the pandemic had the potential to interrupt people. So in the same way that it had the potential to interrupt people's treatment where they weren't in clinical trials, just their routine access to treatment, it also had the potential to interrupt the access to treatment that people had through clinical trials. And I think that different trials had different experiences of disruption during the pandemic. But I think where access was continued, it was because of collaboration. It was because the centres found ways to continue to engage their trial participants. The collaborations that existed and that were created and reinforced, the relationships between pharma and the trial participants and the researchers, in many instances were really, really strong, and so enabled us to overcome these difficulties. And I know that the experience hasn't been the same in all trials and across all organizations, but what really comes home to me is how important relationships are, and how none of this can be about one particular group of people. It's always about a collaboration, and a collaboration that puts the patient at the center, always, I think.
Fantastic. Thanks, Neko. And Fiona, final thoughts on what lessons you've seen or learned? Fiona,
one of the things it's really shown me is how we still have such health inequalities, and that still needs to be tackled. And for a first world country, I find that really quite sad, that we have this disparity. But on a positive note, I think some of the vaccine and the way that the vaccine programs have been rolled out and people have responded to that has been excellent. So I think there's lessons for that as well. And finally, I think the point by John Dugdale was very good, that people suddenly testing became normalized, and it will be really, we've lessons to learn from that in the field of HIV.
Great, thanks, Fiona. So, colleagues, I wanted to reflect on this because a leadership book that I'm currently reading is by Marshall Goldsmith. It's entitled "What Got You Here Won't Get You There." And it's about the process of change and transformation in leadership. But in some ways, as I've been reflecting on the HIV pandemic, is it true for us as well that what has got us here won't get us to that final mile? And I wonder if, building upon some of these lessons from the pandemic, we can use this to do some of the transformation, but also recognizing what's essential for us, Neko, relationships, dealing with inequalities. Chloe, let me bring you in here.
Yeah, thanks, Kevin. I mean, it's really interesting hearing you frame all of this. It's fascinating. I sort of hesitated to interrupt you in any way. I mean, I guess the question that I'd want to ask in this situation, in terms of this moment of transformation or change, is really of what I want to ask is, as a doctor practicing in HIV, is of Simon and Sophie more than anything. What do you need us to do now? You know, you've watched all the disruptive change of COVID. You've seen everything that's possible, how suddenly things can become possible. As physicians, we've tried to support. You know, I've tried to demonstrate the tradition of activism from physicians. What do you need now? What do you want us to do? What is the next thing that you think? You know, and how do we ask this question? You know, in a bigger way. You know, how to harness this change. That would be my question.
Mm-hmm. Great, thanks, Chloe. And maybe this is a great time to bring Simon and then Sophie in on this. We have just a few minutes left, but Simon, what are your thoughts? What do you need now?
So it's easy, Chloe. We want you to continue to look after us, you know, and make sure you're making decisions based on the latest research and the latest information, and that you include us as partners in those decisions. And we also recognise that you're all doing this against the incredibly difficult background of cuts and restricted budgets, and so we sort of had that awareness of difficulties, you know, and that to carry on with what you're doing, because we've been very lucky to have such amazing care all this time.
Yeah, thanks, Simon. Sophie.
Thank you. Thanks, Chloe. I mean, I do obviously want to echo what Simon has said, but I am going to speak again and I hope this isn't too restrictive, but having reached out to community members, we have over the years and more recently, devised and developed specific asks that is solution focused. And I know, because I know you and I know the work that you're doing at BART and your new SHARE collaborative around research, we would just ask around to ensure the meaningful involvement of women, but I will say that across genders, because it is about reaching everybody to ensure that we, can reach zero by 2030. But the meaningful involvement of women living with HIV at all stages of research, policy, service design and evaluation, with the inclusion of people from racially minoritized backgrounds so that the diversity of views are represented. And just less formed is having recently done a survey to help inform the Women's Health Strategy. There is a big ask coming from women around more information about future treatment options and availability. Obviously, more inclusion in clinical trials, and I know that you're doing work around that. We know that work is happening, but 19% inclusion entering our 5th decade into HIV is not acceptable, and I know that you know that. So it's, collaboration with the community, with the patients, and yeah, just to build on what you and a lot of other clinicians, pharmaceutical companies, etc. are doing. There has to be support at an institutional level, globally, nationally and locally.
Absolutely. Now, thank you, Sophie. And again, the clarity of those asks and the sense of focus and urgency that we're taking as we emerge from this pandemic, I think has to be a key part to answer your question, Chloe, on what's needed next. The specificity of the asks, the focus on what we're trying to achieve, but also the behaviors to get there. So colleagues, in the final few minutes then of the session today, this evening has been about perspectives. It's been about narratives. It's been about looking back over the past 40 years, but also beginning to think through and to think about how we're fundamentally evolving and changing, both as a result of the HIV pandemic and our current experiences as we enter the final mile in ending transmission of HIV in the UK. As we close, I'm going to ask one final quick question of each participant, and we literally have 30 seconds each. And it is to say, when we stand in 2030 and we look back to 2021, what narrative will we say? What narrative will we speak? What story will we say about our work in the 20s that we had done to get us to that point? So with that, I'm going to ask, I always like asking difficult questions. So Neka, I'm going to start with you, then Simon, and then Chloe. 30 seconds each. What story should we be talking about in 2030 about now?
I would say that in 2030, people living with HIV should have access to, individual people should have access to treatments that suit them, that allow them to take their medicine as it should be taken with the smallest impact possible on their quality of life, and to be able to have the quality of life that they want.
And to say, and your story of what we did in 2020 to achieve that would be? We sought to understand what people wanted, and we acted on it. Exactly. What is the narrative that we will tell of this journey in the final 10 years of HIV transmission? So I think I said Chloe next, so I'll go to you, Chloe. And if you could flick your camera on, Chloe, if you'd like to, so that we can see you and say goodbye.
Sorry, I think it is on, hopefully. I think my part of the narrative would be, what have we learned from HIV in our journey for other conditions? How have we helped to move long-term health better in medicine in general? What have we done that can be extrapolated to other areas, like with the pandemic and contact tracing? What can we give from everything that we've learned and our incredible collaboration?
Fantastic, thank you. Sophie and then Simon.
That feels like such a huge question. I'm almost like, I don't know. It's awful. I hate these.
I'm happy for you to pass if you'd like, Sophie.
Can you just pass for the minute?
Absolutely, absolutely. You know, it is a difficult question because one of the things that we need to do is to visualize the end, to visualize our journey and to be in that space and to look back and be able to say, we are here because of what we did. And we're here because of the sacrifices we've made, of the decisions that we made, and the ways in which we fundamentally changed the way we think about this pandemic to get to that final mile. So rather than picking on Simon and Fiona, would you like to contribute, either of you, before we close the session? Simon?
So yeah, you know, I'm a bit impatient and I want more than I'm ever going to get. I want to be doing this in 2025. I want to look back and see by 2025 we should really have capped the HIV transmission stuff. Really. And then I want to check that the next decade, you know, I don't have many decades left, and so I want to know that there's better understanding of HIV, aging and HIV, that really for those of us that are still around, you adapt to our care and we don't get lost in a dead end of the NHS, really, that those services continue. And I'll be looking back to see whether how we responded to COVID vaccines, because that's the big question for me right now.
Absolutely. Thank you, Simon. Fiona, final word.
So I hope that the skills that nurses have learnt for advocacy, person-centred care, partnership working and prescribing will be transferred into other fields so that there is health equity across the board. And that will be my hope, is that no one is left behind.
Fantastic, Fiona. What a wonderful way to end the session, because that intention starts today as we begin the process of recovery, of restarting and rethinking life post-COVID, knowing that once our eyes have been open to inequalities and what drives them, and once our eyes have been open to the use of technology, new ways of thinking, and as you said, Chloe, unleashing innovation, we can't put that genie back in the bottle. Colleagues, thank you so much for joining us this evening. It has been such an honor to be able to co-chair this session. I'd like to thank the Worshipful Society of Apothecaries and colleagues in the Fast Track Cities Initiative, Fast Track Cities Initiative for London, but special thanks as well to Maria and Eleanor for the work that you've done in ensuring that this entire session went as successfully as it has. Colleagues, thank you so much for joining us. 40 years behind us, 10 years ahead of us. We have the tools, we have the lessons learned, we have the passion, and we have the energy for this next 10 years. Thank you so much, and thanks again to my co-chairs, Jane Anderson and Duncan Churchill this evening. Bye everyone, take good care.
Are we going to stay on?
Might be quite good to get a quick debrief.